We're going to be talking about major acetabular reconstruction in revision total hip arthroplasty, take you through quite a number of clinical cases, and share with you my thoughts on how to approach them for the particular types of reconstructions that are required in today's armamentarium. So when we think about complex acetabular reconstruction, the failure of an acetabular component leading to revision hip replacement is frequently associated with significant loss of periacetabular bone as a result of bone resorption. And this can be made even worse by the surgical trauma at the time of implant extraction, leaving considerable acetabular defect to reconstruct. This is a daunting process, not only in planning, but in execution. The aims, no matter how difficult, however, are the same. That is to reconstruct bone defects, secure firm primary fixation, and then ensure longevity of your fixation by promoting biological fix and load bypass the major deficiencies, trying to restore the hip cent where possible. Now, you can use Poprosky's classification, which I would recommend, but due to time constraints, I'm not going to run through the details of this, but you should look for the integrity on x-rays of the weight-bearing dome, the medial wall, particularly the ischium and the pubis. These are indicators of the extent of bone loss and the type of reconstruction you're going to need. In principle, if the acetabular component migrates superiorly and laterally, you will lose more of the posterior column. If the acetabular component migrates superiorly and medially, you will lose more of the anterior column. There are a number of options for acetabular reconstruction. I'm going to discuss most of them, but I won't be discussing en bloc allografts or impaction grafting. But I do have experience with jumbo cups, porous cups, reconstruction rings and cages, bone grafting. We're going to be talking about trabecular metal augments, cup cage constructs, and also talk about triflange custom implants for the most severe of acetabular reconstructions. If you want a good synopsis, this paper by Won Shon from Seoul, Korea on acetabular reconstruction and total hip arthroplasty is a good review of this topic, published at Hip and Pelvis in 2016. Let's start with type 2C, isolated medial migration in these screw-in cups over a number of years can lead to significant defects, particularly of the anterior column. Because they're slow in migration, often there's a shell of bone, and that can be a rescue because you can impact graft into that area, get a good rim fit. And this type of reconstruction is serviced with a jumbo cup, in this particular instance, an 80mm porous cup, augmented by 2 or 3 screws fixation into the ilium, significant morselized bone at the bed of this, and over a period of time, this will consolidate, giving you good bone reconstruction. Should you need to go back for a further revision, at least you have a good bone bed to work with. This is a fairly straightforward reconstruction if you can get a good rim fit. If, however, a rim fit is not possible due to a more extensive lysis, then acetabular cages provide an effective means of transmitting loads to stronger cortical bone away from the defective acetabulum. There are 2 groups of cages, the anteprotrusio rings and load bypass cage. Addressing the anteprotrusio cages, like the Gans cage, it's effective for types 2 and some type 3 where the teardrop lysis is only mild. Therefore, you can use the obturator hook to actually secure fixation distally. This necessarily brings the center of rotation to the correct position so you don't have too much proximal migration of your new cup. This restores the hip center, provides uniform load to the allograft bone, stimulating incorporation and remodeling with the remaining host bone. The liner can be independently cemented in the best position for stability. The cement used can be loaded with antibiotics to decrease the risk of sepsis in these major reconstructions. And the cage protects the structural or morselized allograft underneath while it incorporates and remodels. This is an example of one that I put in, and here you can see there was a good bone bed, but it gave us good security with the obturator hook, 3 screws to provide further stability. There is a potential of putting more orthogonally angled screws into the island, but this was not necessary in this circumstance. This is a fairly straightforward reconstruction. In much more significant defects, the load bypass cages are much more rigid, definitely stronger. However, they are difficult to apply and they're difficult to adjust intraoperatively, but time taken is well spent. It expands the area of contact with the host acetabulum. The iliac flange and the ischial wing provide load bypass for the grafts underneath, but primary fixation must not be dependent on cement. The Bert Schneider cage is a good example of this, and it is relatively inexpensive. Reconstruction cages require the integrity of the posterior and superior part of the acetabulum and at least 30% host bone contact. You can see here the onlay technique with the ischial flange lying on there, and 2 or 3 screws can be put into the ischium to secure the Birch-Schneider cage inferiorly, or alternatively what's recommended is to create a small trench and do an inlay technique with the bent ischial flange put into the ischium and then secured proximally with iliac screws in 2 different directions. Well placed, it secures good outcomes. Dan Berry reported on this, 76% survivorship at 5 years, while Gill reported 79% survivorship at 8.5 years. This is a good example of mine 20 years after bilateral total hip replacements, came to see me with significant osteolysis from polyethylene disease, cement disease, significant migration of both acetabular components, and on the left side, most likely a pelvic discontinuity. We did a Birch-Schneider cage on both sides in separate sittings. You can see already at 1 year the extensive bone grafting on the right side, which was certainly the more successful of the 2. And over a period of time, the right side remained stable and completely pain-free. The left side had minor symptoms. And at 15 years, the right side still remains pain-free, still remains stable, good bone restoration, corporation, and still a good outcome for this patient 15 years down the track. The left side, however, continued to migrate, inadequate bone support behind it, and at 10 years it failed. So what do you do in that circumstance? The cup cage construct, reconstruction of Poprosky 3A and 3B for pelvic discontinuity as well. The porous cup is fixed in the pelvis with screws on an allograft bed, recon cage over the cup with multiple screw fixation to both the ilium and the ischium. Skulko in 2017 reported on 57 patients with Poprosky 2B to 3B. 60% of those cases had associated pelvic discontinuity. Survivorship at 2-year follow-up was 89%. That's a good outcome for these complex cases. So in this patient of mine who failed at 10 years, principally due to a leg length discrepancy as it shortened with a limp and some pain, required reconstruction. The construct was extracted, the bone bed prepared, morselized graft was impacted into the soft tissue and the bone bed, and this was stabilized then with a large giant titanium shell, highly porous with multiple screws through the dome. This was further stabilized then with a cage construct into this, and then the polyethylene liner cemented in situ. Post-operatively, this was the appearance. It gave good stability, lots of new bone in the area, and now past 6 years, you got good bone incorporation, good stability, no migration, and a good outcome for this sort of difficult reconstruction. There are modular augments now that you can use. These are available, and this is an example of a progressive groin pain for 5 years after a revision femoral reconstruction in a 72-year-old lady. You can see here failure of the acetabular and the polyethylene component, and using one type of these modular implants like the Lima Recon cage with multiple augments, particularly superiorly, you can fill in the defects with either titanium or tantalum, morselized grafting and multiple screw fixation to give you good outcomes. Perdicarini in 2021 reported 88.5% survivorship at 6 years using these constructs. But even these constructs can fail, and when they fail, it becomes an even bigger problem, where here there was a dissociation between the tantalum cup and the tantalum augment, which remained in situ. This lady came to see me with problems on both sides. She required a reconstruction, and really the only option I could see here was a patient-matched implant. These custom implants use solid engineering to address the most complicated cases of loss and deformity. They can be done using either CT or MRI, and are custom made to the patient with CT 3D printed implants that you can visualize, you can see it electronically, you can palpate it, you can take it to the operating theatre. It manufactures the 3D triflange cup. It also shows you the trajectory of the screws you're going to put in. It tells you how long the screws are so you avoid complications, and you have this in the operating theatre. This was her outcome, and at 3 years she was doing well, came back requiring revision on the opposite side. Another example of a catastrophic hip failure in this patient who eventually lost it all, again done with custom-made implants, the CT scan for the patient-matched implant, the triflange cup, the trajectories of the screws, and then the insertion. These are not easy surgery. It is difficult. It takes a bit of time, but it's time well spent if you get an outcome like this with good stability and the patient is walking at 6 weeks comfortable again after a year or so of discomfort. The results in the short term do show complication. 19 hips using triflange custom implants, 65% successful, 11% failure, 16% major complications. So you have to be realistic. Here, 57 revision total hip arthroplasties in Christie's group, 2 to 18-year follow-up, 95% free of revision, 65% free of revision for any reason. There is therefore a complication rate, and Meinke in 2017 with the Belgium experience demonstrated this in a table that showed all triflange cups, and conclusively in 282 patients, the complication rate was 26%, the dislocation rate was 14%, revision rate 18%. So the complications, predominantly dislocation or infection, are the ones we worry about, but nerve palsy, component loosening, and altered gait biomechanics are a problem. So in conclusion, this is big league surgery with major consequences if things don't go to plan. So plan your surgery very well. You have numerous options to choose from, but you have to have realistic expectations, and you need to impart these onto your patients.